Welcome to another edition of the Neurocritical Care Society podcast. My name is Joshua Levine. This week, we will be reviewing the recently published report by Basha and colleagues in Neurocritical Care titled Acute Resective Surgery for the Treatment of Refractory Status Epilepticus. It was a retrospective observational study and literature review on the safety and efficacy of surgical resection to treat patients with refractory status epilepticus. Dr. Starane Shepherd from Rush University Medical Center will conduct the interview.
Hi, I'm Starane Shepherd, Assistant Professor of Neurology in the section of Neurocritical Care at Rush University Medical Center in Chicago, Illinois. My guest for today's podcast is Dr. Maysa Basha, an Associate Professor of Neurology at Wayne State University School of Medicine in Detroit, Michigan. She is the first author of a very interesting paper that was recently published in Neurocritical Care, titled Acute Receptive Surgery for the Treatment of Refractory Status Epilepticus. Thank you for joining us, Dr. Basha.
Thank you for having me. I'm very excited to discuss this topic with you today.
Before we get started, can you tell us a little bit about how you became interested in this topic?
That's a good question because I am an epileptologist, so I'm not on the front lines of status epilepticus treatment. I'm more on the background reading the EEG. But I do work at a very collaborative environment. We have a very good relationship with both the neurointensivists and the neurosurgeons at our center. So this laid the groundwork for a good clinical environment where everyone is interested in patient outcome and later sort of fed into a research interest for me personally and for the group.
For the non-neurologists listening to this podcast, we should start by defining terms. What is the difference between status epilepticus, refractory status epilepticus, and superrefractory status epilepticus?
We can define status epilepticus as persistent or recurrent seizures without intervening recovery, which results in a condition that's fixed. It's quite different from individual seizures, actually. The timeline by which this occurs has been a moving target. Classic definitions have suggested about 30 minutes of continuous seizures, but over recent years it's been well accepted that 5 minutes of bilateral tonic-clonic activity should be considered as status epilepticus. The idea is most seizures should stop at 2 to 3 minutes, so at 5 minutes you have a failure of the intrinsic mechanism of seizure termination, which we don't quite understand. The timeline for focal status epilepticus is not as clear, mostly because we don't have enough information or data. Most recently, however, the International League Against Epilepsy has proposed 10 minutes duration that constitute status epilepticus for focal seizures, with or without impairment of consciousness. But it does not necessarily mean it requires the same rate or type of intervention. These definitions clearly push us for earlier intervention, which includes benzodiazepine as first-line agent and an IV anti-epileptic drug as a second-line agent. When seizures continue despite administration of these first- and second-line agents, then we are dealing with refractory status epilepticus. In the case of tonic-clonic seizures, this requires quick action in the administration of IV anesthetics like propofol or midazolam. And if we continue to see seizure activity for 24 hours or more, despite having these IV anesthetics on board, then that's when we are dealing with superrefractory status epilepticus.
As a neurointensivist, I'm often admitting patients with status epilepticus and refractory status epilepticus. Why is it important to treat these patients quickly and aggressively? And what, if any, are the long-lasting effects without early intervention?
We know from animal models that prolonged seizures result in irreversible brain damage. We do have those studies in the humans which demonstrate evidence of neuronal injury and loss. We have demonstrated focal atrophy, for example, on MRI in regions of status. We also know that the duration of refractory status epilepticus does matter. Shorter duration of refractory status has been associated with better functional outcome. Now, of course, there are many other factors that are in play, including the underlying condition, comorbidities, and the type of status, which should be considered when we treat these patients.
And in your study, you evaluated the safety and efficacy of surgical intervention in patients with refractory status epilepticus. We, as neurologists, often consider this in the outpatient setting for patients with epilepsy, and not often in the ICU for a patient admitted in status. Surgery is not something we typically think of, especially in patients without a known seizure history. Why is this something neurointensivists should consider?
We know that this has been considered in the past in young pediatric patients, but it is a bit more challenging for the adult patient. It's not as simple in the adult population because there's a lack of a fixed target. There's no malformation of cortical development. There's sometimes no known history of epilepsy. But we do know, although the literature is very scant, successful surgical treatment of status has been demonstrated. The key moving forward will be identifying which candidates will benefit and can be good candidates.
Knowing this, let's delve right into your paper. Can you comment on the study design, the study population, and the primary outcomes your team selected for this investigation?
We first did a retrospective review of all adult patients that underwent epilepsy surgery at our center over a 10-year period. We identified then the ones that underwent acute surgical intervention for status epilepticus. We also looked at the peer-reviewed adult and pediatric literature for studies where surgical intervention was used in a similar way for ongoing status. We included only the publications that contained details with regards to demographics, etiologies, and management. Our focus was to review patients who underwent resection or disconnection, so things like cases where vagal nerve stimulation or cortical electrical stimulation were used, those were excluded. We also excluded some common syndromes where there was an established role for surgery, like Rasmussen encephalitis and ESES, electrical status epilepticus, during slow wave sleep. The primary outcomes, essentially, did the status stop? Did the patient go home, or was he or she placed in a nursing home? And what happened to the seizures? Did we have adequate control of seizures, seizure freedom, or did status recur?
Can you describe the characteristics of your cohort and how these patients responded to surgery for refractory status?
This cohort consisted of 9 patients who underwent resective surgery. For the most part, these were considered for surgery as a palliative option. 8 of the 9 met the criteria of super refractory status epilepticus, where they failed multiple anti-epileptic drugs and had received different types of IV anesthetics. Patients were in status on average of about 25 days before surgery was done. The longest was 54 days, almost 2 months, and the shortest was 10 days. 6 of the patients had resolution of status epilepticus after surgery. 4 of these remained seizure-free, and the other 2 had recurrence of status 1 to 2 months after surgery. Overall, we had a rate of 56% seizure freedom in our cohort, and that rate was the same when we pooled all the patients with known seizure outcomes together. That would include our cohort and the literature review cases. An additional 31% had significant seizure improvement, also when we pooled all the patients together.
In performing this retrospective review, which patient characteristics were associated with more favorable recovery following surgical intervention?
With a small cohort, especially a retrospective cohort, it was difficult to provide significant risk factors that can predict good outcome. We did notice, however, that MRI is important. Patient with multilobar involvement, whether it was hyperintensities on T2 or FLAIR images or multilobar lesions, those patients did not respond to acute resective status surgery. Also, patients with a lack of congruency between MRI and EEG either did not respond to surgery or status later recurred. The high variability of etiologies prevented us from commenting on etiology as a factor. But we did notice that de novo status, interestingly, which is not typically something that is considered often in the pediatric population, was pretty prevalent in the adult cases that were published and our own adult cases. We had 10 cases in total, and nearly 60% resulted in total cessation of status with surgery, with most having seizure freedom or significant improvement.
What would you say are some of the limitations of your study, and what questions remain to be answered?
Obviously, we had high variability in the timing of surgery, variability of anti-epileptic drugs used and IV anesthetics used, which are big limitations. And they're mostly a product of a retrospective study. In our literature review, we also encountered publication bias, especially we reviewed case reports and small case series that were included. Because of the complex nature of status, we may be limited to retrospective review, but I think we definitely need larger numbers before making a final conclusion as to the timing of resective surgery for status.
So based on the results of this study and on your experience, when should I consider receptive surgery in a patient with refractory status epilepticus rather than continued escalation or modification of IV anesthetics?
That remains a very difficult question to answer, but I do think we should start considering status surgery within the first week of refractory status epilepticus. At that point, it would be important to have an MRI and correlate with EEG, have an autoimmune workup which may or may not preclude the patient from surgery, and at least have the presentation of the data at your epilepsy surgery conference. Certain surgeries will carry different comorbidities and different expected deficits, so it will be patient-dependent as to when will benefit outweigh the risk. We obviously advocate following the status epilepticus algorithm of first-line and second-line treatment, and for refractory cases, this should be followed by IV anesthetics and EEG monitoring. We then recommend obtaining an MRI, and if we identify focal changes that correspond with focal EEG abnormalities, these patients will make the best candidates to be considered for status surgery. If the patient presents as a de novo status, we do feel that it's best to rule out autoimmune infectious causes and perhaps an empiric treatment with immune-mediated agents may be considered before pushing the patient back into our algorithm. Likewise, non-focal MRIs and EEGs may be tried with alternative therapies, ketogenic diet, for example, before considering resective surgery if we're dealing with prolonged supra-refractory status.
Thank you, Dr. Basha, for taking the time to speak with us today about your study that was recently published in Neurocritical Care. Status epilepticus and refractory status epilepticus is something we see a lot of in the Neurocritical Care unit, but I think we should consider more and more these alternative interventions, like receptive surgery, in patients suffering from this disease. Thanks for joining us.
Thank you for having me.
That was Dr. Starane Shepherd, Assistant Professor of Neurology at Rush University Medical Center in Chicago, interviewing Dr. Maysa Basha from the Wayne State University School of Medicine. This podcast is produced by the Neurocritical Care Society, whose mission is to promote quality patient care, professional collaboration, research, training, education, and advocacy in neurocritical care. The Neurocritical Care Society provides and advocates for the highest quality of care for patients with critical neurological illness throughout the world. Follow us on Twitter @Neurocritical, on Facebook, or visit www.neurocriticalcare.org for more information about NCS and the comprehensive resources that it offers. This is Joshua Levine on behalf of the Neurocritical Care Society. Thanks for listening.